morning, good afternoon, good evening, wherever you are in the world. Thank you very much for taking the time out to join us all for what promises to be a really interesting 1 hour of your time. So we've got a very lively agenda over the next 1 hour. We are really privileged to have two wonderful speakers who will be talking about various aspects of thyroid hormone action. My name's Salman Razvi. I'm a clinical academic at Newcastle University. And for those people who do not know where Newcastle is, it's in the northeast of England in the UK. My area of interest is around the cardiovascular effects of thyroid hormones. And therefore, I'm really looking forward to what the effects might be on other aspects of the human body, such as the liver as well as the kidneys. And as you're all aware, all these organs are very well connected, particularly if you are thinking about the cardio-renal metabolic aspect of it. I have no potential conflict of interest to declare for this particular activity. A little bit about the providers. So we're really grateful to MedEA, their Medical Education Academy. It's a global provider, and its work has involved designing and delivering and also then evaluating medical education activities throughout the globe. They offer support to a lot of healthcare professionals, and it's been really wonderful to work with them in delivering this to you. And once again, thank you to everyone for taking the time out. I realize it's about 11 in the morning in Latin America, and I understand it's about 10 o'clock at night in China. So thank you for your time. We have had other activities organized via MedEA. So we had a video interview back in April. We had a podcast and infographic in July. We have had work about the cardiovascular effects of thyroid hormones. We've had some lectures about thyroid hormones in pregnancy. And then today is the live webinar that has been organized. A lot of organizations are in partnership and have endorsed this webinar, including the Portuguese Society for Diabetes, Metabolism and Endocrinology. We've had the Argentinian Society for Endocrinology and Metabolism, which has also endorsed this. The Latin American Thyroid Society have been supportive, as has been the British Thyroid Association. We'll be particularly thankful to Marcelo Vitali, who's the president of the Argentinian Society for Endocrinology and Metabolism, for his support in this endeavor. And also Merck Healthcare, which is a global thyroid hormone, which also deals with thyroid hormone amongst other medicines, has supported this partnership and has provided us with an independent grant. So over the next 1 hour, we'll have Professor Hollenberg, who will be talking about the function of T3 in mast cells, and that'll be followed by Dr. Brenta talking about the cardiorenal metabolic consequences of hypothyroidism. And then we'll have 10 minutes of discussion and debate, friendly all in all, and then we'll close in about an hour's time. You've been aware of the learning objectives, which are on your screen, and hopefully at the end of it, we should have all of you scoring highly on this. This is accredited for a European Council for Continuing Medical Education. One thing to remember is once this is finished, if you could all complete the survey that'll come out, you'll then be able to obtain a certificate of attendance at this meeting. I'm sure by now you'd have realized that this is simultaneously being translated into Spanish and Chinese, obviously along with English that you can hear directly. The question and answers, we hope you'll be able to write them down in the chat box down at the bottom, and we'll collate these questions and we will be asking those two are panel. And hopefully we should get really interesting answers. So we have, first of all, Professor Tony Hollenberg from Boston will be talking to us about the effects of thyroid hormones on the liver, particularly around MASLD, or metabolic associated steatoliver disease. He is the president of the Boston Medical Center and professor of medicine at Boston University School of Medicine. Dr. Hollenberg earned his medical degree from the University of Calgary, and then he also served as chief resident at the Beth Israel Deaconess Medical Center. He then completed his fellowship in endocrinology, diabetes, and metabolism at Massachusetts General Hospital. And Tony Hollenberg is renowned for his work on physiological and molecular mechanisms of thyroid hormone effects on metabolism and tissue thyroid hormone effects. Tony will be followed by Dr. Brenta, and I'll say a little bit about Gabriella Brenta in just a few minutes. So, without any further ado, let's go to Professor Hollenberg.
Great. Thank you very much. It's a real pleasure to be here, Professor Rosvi. Thank you for the kind introduction. It's a pleasure to share this webinar with Gabriella Brenta. We're going to try and link our talks together and make sure that we give you a good perspective on the role of thyroid hormone in diseases of the liver and kidney. I'm going to focus on the liver and the epidemic of metabolic dysfunction associated steatotic liver disease, MASLD, formerly NAFLD, and focus on the role of thyroid hormones in both the pathogenesis and then the treatment of this disorder. I have nothing to disclose regarding this talk. At the end of this talk, I hope that you will all understand how thyroid hormone acts in humans to regulate metabolism and how thyroid hormone is the most important hormone in humans. I've added that. To determine how low thyroid hormone levels could impact liver function and metabolic disease, and appreciate that engaging the thyroid hormone signaling pathway in the liver, either through the addition of thyroid hormones or new analog therapy, can treat metabolic dysfunction associated liver disease. To do this and accomplish those learning objectives, we'll have three components of this talk. One, we'll quickly review thyroid hormone action and how the hormones control physiology and metabolism. We'll then review briefly the clinical consequences of hypothyroidism, subclinical hypothyroidism, and their relationship to metabolic disease. And then we'll try and understand how thyroid hormone can be used to treat metabolic complications of obesity and diabetes with novel therapeutics that have been designed from thyroid hormone. So shown in the middle of the slides are the thyroid hormones, or the elixirs of life, as I like to say. T4 and T3, the only iodinated proteins in the human body. T3 is the biologic actor, but T4, as you know, is the preferred treatment because it is converted to T3. Thyroid hormones are absolutely required for development and shown as a tadpole, which can't become a frog if thyroid hormone is not present. In humans, thyroid hormone has critical effects on growth and development and regulates neurologic function, cardiac function, hepatic function, bone metabolism, muscle metabolism, and energy expenditure through its targeting of fat tissue, including brown fat. In fact, there's not a cell that I know in the human body that does not respond to thyroid hormone. And we'll hear a lot about the kidney later on the second part of this webinar as well, and to understand the unique roles that thyroid hormone plays in renal function. So, as I told you, thyroid hormone acts on every tissue in the body, as displayed here in this slide. And to interpret thyroid hormone function in humans, we used the thyroid stimulating hormone assay, which is a hormone released from the pituitary and is under the control of feedback inhibition by T4 and T3, which set the TSH at a particular level for a particular individual. And there is a normal range that we'll review, and it is one of the most widely used tests around the world, and is the screening test to diagnose disorders of thyroid hormone action, or commonly referred to as hypo and hyperthyroidism. Thyroid hormones circulate, as I said, throughout the human body and target every cell. What's fascinating about thyroid hormone is that it enters cells through unique transporters that exist on cell surfaces, and there are different flavors of these transporters. The most famous of them is the monocarboxylate 8 transporter, or MCT8. Once taken up into cells, thyroid hormones can be then activated or inactivated. I told you that T3 is the biologic congener, or the active moiety that mediates most physiologic actions. So T4 circulates in far higher concentrations in the blood, and once it gains access to cells, it can be activated by a family of deiodinases to T3. T3 can also be converted to and activated by another deiodinase, the type 3 deiodinase, to reverse T3. However, the cell can then set its own level of T3 that it makes, so to speak, and once made, T3 then enters the nucleus, where it binds to receptors for thyroid hormone that then regulate physiology by controlling gene expression. T3 can also regulate through its receptors rapid actions as well without binding to DNA, but these are not as important as the genomic actions of thyroid hormone. And I just want to introduce at this point in time that there are two flavors of these receptors for thyroid hormone. There's the B or beta receptor, which is primarily expressed in the liver and in the pituitary. And then there's the alpha receptor, which exists in the heart and bone. So immediately you could see that different effects of thyroid hormone are mediated in different tissues by by different receptors, so to speak, which will give us an opportunity later on as we discuss novel ways to treat metabolic disease. But the take-home message here really is that thyroid hormone gets into cells via transporters. The local amounts of thyroid hormone, or T3, in a cell can be controlled by deiodinases, and then physiology is regulated by the thyroid hormone receptors. Let's move now to hypothyroidism in metabolic disease. Clinically, patients with profound or overt hypothyroidism often present with fatigue and lethargy. They can have general signs, which include slow speech, slow movements, and bradycardia, or a slow heart rate. Specific signs, when examined, can include a goiter, potentially delayed reflexes, and even muscle weakness. Non-specific laboratory values include a high creatinine kinase, a high liver enzyme level, or AST, and a rising cholesterol, in particular LDL cholesterol level. In fact, if one sees a patient with a sudden increase in LDL cholesterol that's otherwise unexplained, please think of hypothyroidism. To make the diagnosis, as we talked about, TSH is the best screening test. And once established that the TSH is above the normal range, or above 4.5, it's best then to reflex and measure circulating thyroid hormone levels, which is most commonly done with a T4 or free T4 assay in the blood in order to confirm the diagnosis of hypothyroidism. So overt or hypothyroidism is a recognized clinical diagnosis, and one that has clear signs and symptoms as just reviewed. However, more common is a disorder that we call subclinical hypothyroidism. These are patients who are generally asymptomatic with an elevated TSH, usually between 4.5 and 20, who have a normal free T4. There is some debate regarding the upper limit of normal, but Dr. Brenta and I both agree that 4.5, and I think Dr. Osvi would agree as well, is the established upper limit of normal. So subclinical hypothyroidism is a normal appearing patient, otherwise well for the most part, potentially with other disorders, but normal thyroid hormone levels, but an elevated TSH. So what does this mean? Well, it's common. 4 to 5% of women have this disorder under the age of 45. And as women age, it becomes even more common, rising to 17% in women over the age of 75. Lower in men. If there's another autoimmune condition present, such as type 1 diabetes or rheumatoid arthritis, the incidence is even much higher. Many of these patients remain subclinically hypothyroid with an elevated TSH that does not progress. So the real question is, what are the consequences of relatively mild hypothyroidism, yet persistent hypothyroidism? In the last number of decades, it's been clear that rising TSH levels in the range of subclinical hypothyroidism are associated with all-cause mortality due to cardiovascular disease that can be the consequences of associated metabolic disease, including diabetes, steatotic liver disease, and CKD or chronic kidney disease. And these come from large clinical databases. I show you the NHANES data from a few years ago, but these data have been replicated in a number of studies. This work has led to a paradigm of treatment approaches to patients with an elevated TSH, a normal T4, who are otherwise without signs or symptoms of overt hypothyroidism. As I mentioned, when the TSH rises, there's a risk of cardiovascular morbidity and mortality that can be the consequences of other metabolic disease, including chronic kidney disease and liver disease as well. And the clinical suggestions are that once the TSH rises above 7, in those patients who are less than 65, one might want to consider treating, especially if there is the presence of CKD, a metabolic disease, steatotic liver disease, diabetes, or anything else, or hypercholesterolemia. In those over 65, one would consider treating. Once the TSH rises above 10, however, all societies pretty much recommend that patients then be treated with L-thyroxine for subclinical hypothyroidism. So I think what this denotes clearly is that when the TSH is even mildly elevated with normal T4, the body does not have enough T4 for its own actions because the TSH is high. And this low thyroid hormone signaling can have profound consequences in the progression of metabolic disease in the heart, liver, and kidney, as you'll hear later, and probably should be treated in certain situations as outlined in this slide. We do need more randomized controlled clinical trials in this area, but there's a lot of evidence to suggest what I just said. So what about the liver? Thyroid hormone has profound actions in the liver. It regulates fat content by regulating both transport of fat into the liver, how fat is synthesized in the liver, and how fat is oxidized to remove it from the liver. Also, as I discussed, thyroid hormone is one of the most important regulators of cholesterol metabolism in the liver. And in fact, thyroid hormone action is highly related to the development of metabolic dysfunction-associated liver disease. If you look at large population studies, as I show here, with a higher TSH, as you progress from the normal to the subclinical to the overt hypothyroidism range, the incidence of steatotic liver disease rises. While as the TSH falls, even into the hyperthyroid range, the incidence decreases. And this is really, while on the population level, quite dramatic, at the physiologic level, this is confirmed in animal studies where if you remove all of those receptors for thyroid hormone from the liver, livers become fibrotic, which is really the end stage clinical picture from steatotic liver disease, confirming that thyroid hormone action is critical in preventing the development of steatotic or metabolic dysfunction-associated liver disease. So that's when we look at metabolic-associated liver disease, which affects 30 to 45% of the general population across continents. 60 to 70% of those with type 2 diabetes have MASLD. 2 to 3% with just fat in the liver progress to advanced fibrosis. And 25 to 30% of those with fibrosis further progress to potentially cirrhosis and to hepatocellular carcinoma. So ideally, we'd like to intervene and treat MASLD before it progresses to fibrosis and further to cirrhosis or hepatocellular carcinoma. And importantly, in all of these conditions, decreased thyroid hormone signaling can be present. Indeed, there are studies where even giving T4 or L-thyroxine to patients with normal thyroid function can reduce liver fat. So thyroid hormone signaling, because of its physiologic effects on the liver, is exquisitely important in the treatment or in prevention of MASLD. So I'd like to turn, based on that principle of thyroid hormone action in the liver, to thyroid hormone analogs, and which will further underscore the importance of thyroid hormone in the treatment of MASLD. So as I mentioned earlier in the talk, there are two flavors of thyroid hormone receptors, the B, or THRB, or beta, and the alpha, or A, THR alpha. So back in the 1990s, Tom Scanlon and John Baxter hypothesized that they could make a specific analog for THRB, and that this compound would bind to the TRB equally to T3, but not bind to TR alpha. And in fact, that's what they did. And they called this compound GC1. So here you could then potentially think of a specific ligand that could go just to the liver to treat metabolic dysfunction-associated steatic liver disease without having untoward effects of excess thyroid hormones on the heart or the bone. So the first such analog that was given to humans was called KB2115, and this was studied in a phase 2 clinical trial that was published in the New England Journal and led by Paul Ladenson. And this trial showed that this analog, KB2115, which was like GC1, only went to the liver. And what it did was it dramatically reduced LDL cholesterol levels and triglycerides and lipoprotein A with really, really good effects, showing that you could get thyroid hormone analogs only to the liver that would bind to TR beta without peripheral side effects. This drug, unfortunately, had to be discontinued because it had a non-drug effect on bone. Subsequently, though, however, people didn't give up. Two further analogs were developed by a couple of different companies, again with the idea now to go after MASLD and treat fibrosis and fat accumulation in the liver with analogs that would only bind to TR beta. And this is a phase 2 study of the compound that has subsequently been approved. It's the first drug approved for the treatment of metabolic dysfunction-associated liver disease. This compound, resmetirom, or first known as MGL3196, is specific for TRB, and it only goes to the liver. And in this phase 2 study, shown are MRIs showing fat in the liver before, and then at week 12, and then further on in the study, showing a dramatic decrease in fat content, in relative fat content, and absolute fat content in the livers of patients with metabolic dysfunction, steatotic liver disease, suggesting that this could be a highly effective drug. Indeed, in a phase 3 clinical trial performed by Harrison et al. And published in the New England Journal of Medicine, resmetirom was shown to have a 30% effect of resolving inflammation and liver and fat accumulation in the liver in about 30% of patients at a dose at two doses, and the higher dose being more effective. Similarly, it was also able to improve fibrosis in about 25% of patients. So it was able to treat the precursor to fibrosis and also fibrosis by enhancing thyroid hormone action in the liver alone. Also, there were dramatic effects on the reduction of LDL cholesterol in these patients. Based on these findings in large phase 3 clinical trials, this drug was approved for the treatment of MASLD and MASH by the Food and Drug Administration in the United States in 24 and by the European Medicines Association in August of 25. And we're starting to get interesting data back from patients really after its first year of use. Subsequent to the approval of resmetirom, one of the GLP-1 analogs has also been approved for the treatment of the same disorder. However, while I said that these drugs are specific for the liver and don't affect other targets, there was some suggestion in the large phase 3 clinical trial that T4 levels may fall slightly. This is in fact felt to be a liver-specific effect because too much thyroid hormone in the liver can rev up its own metabolism, but I think this bears watching on patients being treated with MASLD to make sure that we're not lowering their thyroid hormone levels to untoward places that could create hypothyroid symptoms in other parts of the body. So with that, I'd like to conclude and then just review what we've talked about. So low thyroid hormone levels lead to metabolic dysfunction. This can even include thyroid hormone levels in the normal range, but are reflected by a high TSH level, like in subclinical hypothyroidism. One can target thyroid hormone signaling to specific cells or even to organs based on new drug discovery methodology and the development of thyroid hormone analogs. What was clear from the clinical studies is, though, that only 30% of patients with metabolic dysfunction-associated liver disease responded to these new thyroid hormone analogs, raising the possibility that even stronger drugs are necessary in the thyroid hormone signaling pathway to treat metabolic dysfunction-associated liver disease. And with that, thank you very much for your attention.
That was excellent, Professor Hollenberg. Thank you very much. We'll come to questions later. And that gives us time to move to the next talk. Professor Brenter is the Chief of Thyroid Division of the Endocrinology Department at Dr. Cesar Milstein Hospital in Buenos Aires, and a professor at the Medical School of the University of Buenos Aires, as I'm sure you all know, is in Argentina. Gabriela is a very active researcher. She has published more than 100 papers on various aspects of thyroid function and diseases. And she has been a pro-secretary of the Argentine Society of Endocrinology and Metabolism. She has served as the president of the Latin American Thyroid Society up till 2019, and has been a member of the Pregnancy and Thyroid Task Force and the Women in Thyroid group in the American Thyroid Association. So without wasting further time, over to you, Gabriela.
Thank you very much, Dr. Salman. And while I share my slides, and let me see, I guess you can see them now, and now it's in full presentation, just to confirm. And I'd like to thank Medea for inviting me to be able to share this live webinar together with Dr. Hollenberg and with you, Salman. It's quite an honor. And these are my disclosures. And as Dr. Tony Hollenberg has already introduced the subject, this will be easier for me. Our learning objectives today are to understand the relationship between lower thyroid hormone levels and kidney disease, and to describe the association or the possible association between subclinical hypothyroidism and chronic kidney disease. And therefore, we will try to identify those patients who might benefit from levothyroxine therapy. And chronic kidney disease is characterized by progressive deterioration of renal function, which contributes to cardiovascular disease. And here I share my pointer. See, the Global Burden of Disease study has evaluated the epidemiology of chronic kidney disease period. And the potential explanations for these findings are that the population has grown, that the population is aging, and the large epidemics of diabetes, that obesity and hypertension that we have observed throughout these years. And this connects to this presentation with Dr. Hollenberg, which discussed MASD and framed it in the broader concept of metabolic cardiovascular renal disease. And the new kidney disease improving global outcomes, the KDIGO guidelines, emphasize the importance of assessing patients' risk and note that there are ways to prevent progression. And it is key to identify other concomitant diseases that may have an influence on this progression. And hypothyroidism may be one of them, and this is why I'd like to introduce this idea to you. Here are the mutual consequences of lower thyroid and renal function. Hypothyroidism has been shown to impair kidney structure in different experimental models and also in humans. It has also been shown that hypothyroidism impairs kidney function, as I will show you in the next slide in detail. And also it has been linked to urological disease, to more prevalence of kidney stones. What we all are familiar with is the effects that chronic kidney disease causes to the thyroid, and especially in particular in patients with advanced kidney disease, we might find dysregulated serum TSH levels, lower serum T4 levels, and what we know as a non-thyroidal illness, which are the lower serum T3 levels characteristic of these patients. Well, this graph summarizes the direct and indirect effects of low thyroid hormones on the kidney. And I will show you in this box the direct effects, which include altered intrarenal hemodynamics, decreased renal renin-angiotensin-aldosterone system production and activity, an increase in tubulo-glomerular feedback that I will explain in the next slide, and a decrease in tubular transport capacity. But indirectly, low thyroid hormones effects on the heart include the decreased contractility, decreased cardiac output, and the effects on the vasculature, which are increased systemic vascular resistance mainly. And through these indirect pathways and the direct pathways, we end by having glomerular alterations, which are characterized by a decreased glomerular filtration rate, a decreased renal plasma flow, and decreased transcapillary hydrostatic pressure. And also collecting duct alterations, which include decreased diluting and concentrating activity and an increased natriuresis in response to volume alterations. As I mentioned, I would like to focus on one of the direct pathways, which is the tubular glomerular feedback under low thyroid hormone levels. And here we can see that the low thyroid hormones lead to reduced sodium chloride reabsorption in the proximal convoluted tubule, which you can look at this graph on the left too, which leads to an increased solute load to the distal convoluted tubule. If we look here, the distal convoluted tubule has the macula densa, and when the macula densa senses this increased solute load, there is an enhanced tubuloglomerular feedback. This leads to signals that end up in vasoconstriction of the afferent arteriole, and this lowers the blood flow into the glomerulus and also the capillary pressure. And thereby, this is how hypothyroidism might also decrease glomerular filtration rate. So, having explained all these mechanisms, you might try to understand why there might be an association between subclinical hypothyroidism and chronic kidney disease. And let me see. There are several studies. I just want to show you this one that show that prevalence of hypothyroidism is much higher in patients with chronic kidney disease than in the general population. In this case, this is a cohort of 461,000 veteran affairs patients with moderate to severe chronic kidney disease. And these patients show that nearly 1/4 of the population, in this population, 1/4 of the patients had hypothyroidism. And if you look into the table on the right, you can see that for every 10 milliliters per minute decreased GFR or glomerular filtration rate, there is an 18% higher risk of hypothyroidism. But now let's look the other way around at the prevalence of CKD according to thyroid dysfunction. And you know that the most vulnerable population for CKD are the adults, the older adults. And this study, this Australian study, evaluated 1,571 participants of 60 years or older. And they looked at different thyroid status groups. And here you have them on this graph. And the outcome here was the CKD. The subclinical hypothyroid group, as you can see, had an increased risk, which was 1.84, the odds ratio of CKD when compared to patients with normal thyroid function. And also, if you, in this table, you can see that patients that were in the highest compared to the lowest TSH quartile had 82% increased odds of having CKD, and this was independent of age, body mass index, and the presence of diabetes and hypertension. Well, this is another cross-sectional study. This one was conducted in a hospital in Buenos Aires, the Cesar Milstein Hospital. It included 246 patients with 65 years or older, and all these patients had high cardiovascular risk. These patients were stratified according to euthyroidism or subclinical hypothyroidism. And you can see that those patients that were subclinical hypothyroid had a 3 times higher chance of having CKD than the patients that were euthyroid. And if you look to the right, we see that TSH was also independently associated with GFR, and this was adjusted for age, sex, body mass index, albuminuria, TNF-alpha, smoking, diabetes, and high blood pressure. So now again showing that in older adults with high cardiovascular disease risk, subclinical hypothyroidism is associated with lower renal function. Now, looking at data at the general population, I show you just one study. This is the ELSA Brazil study, which involved 13,000 patients with a median age of 51 years old. Again, the patients were stratified according to their thyroid status into subclinical hypothyroidism or euthyroidism, or quartiles of TSH within the normal range. And the outcome was chronic kidney disease. Here's the definition. And you can see that subclinical hypothyroidism was associated on this table. You can see the association of subclinical hypothyroidism with GFR, or glomerular filtration rate, below 60 milliliters per minute. And there was also an increased association of patients who had the TSH in their 3rd or 4th quartile compared to the 1st quartile. Well, all these studies suggest an association, but they do not prove causality because they are cross-sectional. But we have some Mendelian randomization studies that suggest that there might be cause that the hypothyroidism and TSH might be related to increased CKD. This is one of them, and there has been another one that has been recently published suggesting the same directional pathway in terms of Mendelian randomization. But another possibility, while we don't have too many trials, as Dr. Holenberg mentioned, that longitudinal studies might give us some idea of what is the incidence of chronic kidney disease as a clinical outcome regarding baseline TSH values. And as you can see, this busy table shows you that there are still conflicting results in terms of this. In blue, there are some studies with negative or neutral results, such as the Rotterdam study, that it even showed that there was an improved outcome in patients with subclinical hypothyroidism in terms of changes in GFR. These were older adults. And this, on the bottom in red, you have several studies that had the advantage of having tested TSH in several times along the way, not just a baseline TSH value, and showed positive values or showed positive results in terms of higher incidence of CKD. And in particular, I would like to show this study, which was performed with a large national US health insurance plan. It's a retrospective of over 4 million patients with normal baseline TSH or thyroid function, and they were followed up for 3.8 years. And then the patients were evaluated for incident thyroid status, and they were categorized as hypothyroid or hyperthyroid or euthyroid. And the outcome here was the composite endpoint of incident CKD or CKD progression. And here you can see 4 models of Cox models for incremental adjustment. They adjusted for several parameters, and here's the most strict model of all. And in all of them, you can see that both hypothyroidism and also hyperthyroidism are risk factors for the development and progression of CKD. So these findings support the hypothesis that reduced thyroid hormone levels have a detrimental impact on renal function. Well, now let's see if we can identify those patients who would benefit from levothyroxine therapy. And I'll show you some of the studies. And before, I would like to show you this busy slide, but just for you to know that along all these years, there have been many case series studies showing that patients that are overt hypothyroid and have a thyroid hormone replacement, their renal function completely improves after the treatment. And this is something that you probably saw in your clinical practice by treating overt hypothyroid patients and looking at their creatinine levels. So this is there is no debate about this. However, there is still some debate on if we should treat or not subclinical hypothyroidism, of course. But this is a study on CKD disease patients with subclinical hypothyroidism. It is retrospective. It included 309 subclinical hypothyroid patients with CKD stages 2 to 4. These patients were followed along 3 years, and some of these patients, 180, were not treated with levothyroxine. The outcome was end-stage renal disease or GFR decline, reduction of 50% or more. And you can see in the multivariable Cox regression analysis that thyroid hormone replacement therapy was found to be an independent predictor of renal outcome. And here in the Kaplan-Meier curve, you can see that the renal event-free survival was significantly lower in the non-treated group. Well, now I'll show you one randomized controlled trials. There are not many in this area. This is a small study on early stage diabetic nephropathy patients with subclinical hypothyroidism that were randomized to placebo or levothyroxine. And levothyroxine decreased albuminuria compared with the baseline levels of albuminuria in this group. And also in this study, several parameters related to oxidative stress, as you can see in these graphs, were evaluated after treatment, and after 24 weeks of levothyroxine, most of these parameters significantly improved compared to the subclinical hypothyroid group that was not treated. Well, this is another retrospective study in diabetic nephropathy patients with subclinical hypothyroidism. And some of these patients, 83 of them, were treated with thyroid hormone replacement. This time, the outcome was cardiovascular events. And you can see in this table all the different models of adjustment. In all of them, thyroid hormone treatment was associated with a lower risk of cardiovascular events. And here you can see also in this Kaplan-Meier curve, the higher cardiovascular event-free survival of patients who were on treatment. Yes, of course, they are all observational studies. This is another randomized controlled trial, very small, in patients with CKD and grade 3 to 5, and also proteinuria. And these patients had a baseline TSH level of 2.5 to 9.9. They were treated for 12 weeks with either levothyroxine or placebo. After this treatment period, albuminuria was reduced in those patients on treatment with levothyroxine, and also there was an increase or an improvement in GFR. Now, again, all the studies are not so positive, and this is a study that has been recently published that used a population-based cohort with a prevalent new user design of levothyroxine. These patients were stratified into those who were using levothyroxine or the non-treated individuals. They were followed for 1.6 years. Here, the primary outcome was end-stage renal disease requiring dialysis or the lowering of GFR of 50% or more. As you can see in this table, there was no benefit in terms of treatment with levothyroxine in these subclinical hypothyroid patients regarding patients that were not treated. And we have to remember that these patients did not have CKD as the other studies that have been showing right now, or the study that I will show you now, which are patients with CKD and subclinical hypothyroidism. And this is a recently published study from the China Renal Data System by Cheng, showing in 30,000 CKD patients, in whom 7.4 of them had hypothyroidism, that the composite renal failure, or that this was the primary endpoint, composite renal failure or all-cause mortality. This was the primary endpoint, and it was shown that that hypothyroidism was related to all-cause mortality and composite renal failure. But what I would like you to focus is on the secondary endpoint, which was the impact of thyroid hormone replacement on renal outcomes. And here in this table, you can see that levothyroxine was associated with significantly reduced risk of renal failure in all hypothyroid patients. So another final study that I would like to show you is this one, which I think it's very important. This is a study of the US veterans population, 200,000 patients with stage 3 non-dialysis dependent chronic kidney disease, stratified according to TSH values, and the outcome here was mortality. Here on the left, you can see that at baseline or in a time-dependent manner, higher TSH values above 3 or more were associated with increasingly higher mortality. But let's look to the right, and this is what's important. Those patients that were treated to target, those patients that were hypothyroid and treated to target with levothyroxine, all-cause mortality was similar to the euthyroid group. While if you look on to the right, hypothyroid undertreated or untreated hypothyroidism had higher mortality. So it's not just about treatment, it's about how you treat patients. And now I'd like to finish leaving these messages to you, which are that thyroid hormones are key to both renal structure and function, and that CKD or chronic kidney disease also affects thyroid profile, leading to non-thyroidal illness. That as renal function declines, the prevalence of hypothyroidism increases. That hypothyroidism might be involved in CKD incidence as a risk factor. That treatment of overt hypothyroidism normalizes GFR. There is no doubt that you should treat overt hypothyroid patients, and that intervention with levothyroxine should be considered in patients with subclinical hypothyroidism and kidney disease. And this is my final slide, and thank you very much for everything, for listening here, and stop the sharing.
Perfect. Thank you very much, Gabriela. That was a wonderful overview of the current state of knowledge regarding thyroid function and renal disease. Right, so now is the time for questions. I don't think there are any at this stage that I can see, and I think unless I'm missing them. In the meantime, can I start with some questions of my own? Probably first to Tony Hollenberg. Now, this is really an exciting time with thyroid hormone analogs, not just being in development, but also actually being used clinically, and the trials are coming out and we are getting some answers. Are there any other conditions where you think tissue-specific thyroid hormone analogs you see might be useful apart from the hepatic aspects of it?
Yeah, I mean, it's a really exciting time for the thyroid hormone field. This analog, idea is 30 years old, 35 years old. And there were older studies, as you probably well know, Simon, on the heart using, DITPA and other thyroid hormone analogs to treat cardiovascular disease and improve ejection fraction that didn't really pan out. So I think there's opportunities again there for potentially alpha analogs or something else that without a detrimental effect, we'll see. But then also people are looking very carefully at the brain to seeing if, there's data in animals that neural inflammation can be reduced, and there's trials in humans looking at the function of of thyroid hormone in the brain to treat psychiatric diseases based on specific uptake of analogs into the brain. So I think that this ability to target an organ, be it the kidney or the liver specifically, and make that organ hyperthyroid while leaving the rest of the body euthyroid, could allow us to profoundly benefit from the wonders of thyroid hormone without the detrimental effects in target tissue. So I think there's going to be a lot more work. And I think the fact that resmetirom was proved to be safe in humans really has led the field in a really strong direction. I do think it's going to be interesting to see how the GLP-1s versus resmetirom do in terms of the treatment. Both are very expensive therapies. And Gabrielle and I were discussing earlier on that there are studies of just using T4 alone in patients with metabolic dysfunction-associated liver disease. So certainly in those with subclinical hypothyroidism, give them T4 first before a more expensive drug.
Certainly. Still can't see any questions, so maybe I'll take the opportunity of asking one other question. Is using these thyroid hormone analogs on the liver, and is this treatment that are coming through resmetirom is one of them. Are there any reliable biomarkers that you can see that will provide an insight into whether these biomarkers are effective or not, apart from standard liver function tests?
Yes, I mean, that's a great question, because the phase 3 clinical trials were really approved based on biopsy, so to speak, and other far more invasive tests. So the non-invasive testing in liver in terms of elasticity, certain other characteristics that form, combined clinical testing are all out there. But I do think we need better biomarkers for liver engagement. Certainly, LDL cholesterol is pretty simple. And if that doesn't fall in treated patients, then you've got to really be wondering if you're really hitting that target in the liver. But again, even using the most sensitive MRI studies and things like that, your point is very well taken, because only 30% of patients who satisfy the criteria for treatment are actually respond. So there's something else going on, and we need to figure out who doesn't respond so that we can put them on other therapies.
And you mentioned about trials assessing the thyroid hormone analogs with the newer GLP-1 receptor. Are there any studies that you know of, or is there any scope for complementary action of these two? So could you have a combination therapy?
Yeah, that's a wonderful question. There have been mouse studies using combination therapies with T3 linked to glucagon or to GLP-1 to treat liver disease, which were very, very effective. So I'm sure some of the companies are looking at that. It's a great idea, right? Because GLP-1 may treat it one way and then thyroid hormone the other way. So be very expensive. So back to making sure we screen for subclinical hypothyroidism and giving L-thyroxine first. But yeah, I think wonderful opportunities to better understand the biology of the epidemic of metabolic dysfunction associated steatotic liver disease.
Thank you. We have a question from one of our attendees here, and I'll read it directly. Hello. Does hypothyroidism decrease the efficacy of other treatments like estroprogestative or antibiotic treatment with a liver effect? I think my understanding of this question is, does hypothyroidism in general reduce the effects of certain therapies with a wider effect, like HRT or some antibiotic that might be metabolized in the liver?
I think Gabrielle, do you want to? Yes, there are some drugs where hypo and hyperthyroidism definitely, interfere with, it could have interfered. Some of the older anticoagulants, definitely some of the anti-seizure medications and others like that. I'm not off the top of my head, certainly the availability of estrogen to affect thyroid hormone binding proteins in the blood. It's quite complicated, but yes, one should look, and obviously and treat hypothyroidism in patients receiving other drugs. Antibiotic therapy, I'm not really certain about in terms of toxicity, but certainly profound hypothyroidism. It could also affect if people are on immunosuppressives for a renal transplant or something like that. You got to watch out for hypothyroidism.
Indeed, I think there is some data about the effect of anticoagulation therapy in untreated hypothyroidism. thyroid in a sense
and
that you're
treated,
offering.
yeah, and hyperthyroidism in particular, those patients on atrial fibrillation, and they might have some less effect of the anticoagulant if you don't, normalize the hyperthyroidism first. So,
Yes.
and as Tony said, there are many proteins that are impaired by hyperthyroidism that are synthesized in the liver, and those alterations in the carrier proteins of several products in blood might, or I don't know about antibiotics, but of course the delayed metabolism or of these elements might also in the liver might be retarded might be present in hypothyroidism. I remember quite a few examples, but it's a very long list because everything is metabolized in the liver. No?
Thank you. Now, here's the question you'd really enjoy, Gabriela. In cases of renal failure, no, sorry, I'll come to the other one in a minute. Do you consider that the reduction in cardiovascular mortality with levothyroxine treatment is more related to its cardiac effects or cardiac contractility rather than a direct renal effect?
On mortality or on the kidney function?
So what the question is that the beneficial effect of thyroxine in say hypo or subclinical hypothyroidism, is that because of a direct effect on the cardiac, or is it because of a direct effect on the renal? Is what the question is.
Well,
what's
regarding
the mechanism?
mortality, yes, there are several possibilities that the metabolic alterations present in hypothyroidism may be involved in its higher mortality observed in large cohorts of patients. The mediation of that relationship between higher mortality and hypothyroidism has been determined, like for instance in the study that Tony showed, the study by Inoue that showed that cardiovascular disease was present as a mediation factor for higher mortality in those subclinical hypothyroid patients. So how hypothyroidism may impact the cardiovascular system involves not only the hemodynamic effects that of course may lead to heart failure or renal impairment indirectly, as I've shown, but there are other parameters acting on the liver, such as the hypercholesterolemia, the high remnant lipoproteins that are very atherogenic and are a result of hypothyroidism that we have shown also in subclinical hypothyroidism, alterations in all the inflammation markers that we already know are linked to increased cardiovascular disease. So there are multiple pathways by which hypothyroidism may lead to increased mortality, mainly probably due to the cardiovascular risk that is enhanced. But that includes all the atherogenic parameters that I've mentioned. And in regards of kidney, I understood the question perhaps differently, because I thought that the question was if the kidney the renal function is deteriorated in a direct or in an indirect way, and which of the two were most important. And here, I don't know if there have been studies showing one pathway is separated from the other. I know there are animal and experimental models showing, for instance, in particular, the thyroid action on tubular function and all the transporters that are linked to sodium chloride absorption, for instance, or calcium, and you can do that in animals. You can separate one nephron and study that in particular. But in humans, you have to think that both indirect and direct pathways are integrated into one another. And what is important is to understand that all these direct pathways that impact on the kidney are impacting on a hypothyroid kidney that is already hypoperfused. So The problem is that the kidney is already under perfused due to these indirect effects on the heart and on the vascular system. So all these direct effects are impacting all these increased tubular glomerular feedback is impacting on a kidney that is already underperfused due to the low thyroid hormones acting on the heart and the vasculature. So the model is completely different to euthyroid patients here.
Thank you. And here's a more practical question. So in case, and this again based on my understanding of the question, in case of renal failure in a patient who's on hemodialysis, when should we dose the TSH for the follow-up? So my understanding is that when should we check the TSH? Is that on the day of the hemodialysis? Is that accurate? Or should we check it a few days before? Or the other way this question could be taken is, when should the levothyroxine dose be given, and when should the effects of that be checked in the blood test? So I think it's basically around the
yes, on hemodialysis and next treatment. And from my research of the literature on this topic, of course, I am not a nephrologist, but what I've read from all these studies on hemodialysis is that hemodialysis doesn't in particular affect thyroid hormone levels. So before and after is the same, and you should administer levothyroxine in a similar way that you do to patients that are not on dialysis. There was somehow some impact of peritoneal dialysis on thyroid hormone levels, but not hemodialysis. So in short, it wouldn't change the way that you do it in the general population.
Perfect. Thank you. I hope that answers the question. I apologize if I misunderstood the question.
No, you didn't. You were right. I misunderstood.
Okay. So I think that's all the questions completed. So thank you, everyone, for your time, for your participation, and for your efforts in attending today, particularly to our speakers who did a great job of educating us about the effects of thyroid hormones on the liver and in the kidneys. So once again, I remind you that please complete the evaluation form at the link provided in the chat on here, and that will help you to claim the certificate of attendance until here. You are able to do this until the 5th of June next year. So once again, thank you to Professor Hollenberg and Professor Brenter for their excellent presentation. I hope we have all learned something today. And once again, thank you for attending this excellent presentation. Goodbye.